I hope you had a nice break and lunch, and you woke up again after some energy. So the topic we're going to talk about this afternoon is a bit different than the topics we started with since the morning sessions. It's one of the most heroic, I can say, it's one of the most heroic situations that can face a physician in his medical career. And it's one of the most stressful situations that we all face. Agree? Cardiac arrest? Yes? And putting in mind in these situations that this patient in front of you is in your hands. طبعاً بعد قضاء الله وقدره, بس whatever you're going to do now, right or wrong, is going to affect this patient's life. And afterwards, his family, his social life, everything afterwards. So, for cardiac arrest being the most stressful situation that you might face, it needs a lot of preparation. It needs a lot of training. Once is not enough, twice is not enough, 3 times is not enough. We have to keep training and training and training and training. And after all this training, we hope we get it right. Because when it happens, it's a major catastrophe. No matter how much nursing, no matter how much physicians you have in-house, it's always a catastrophe. No matter how much you're prepared, it is a catastrophe. Because you cannot expect what's coming through the door and what situation this patient is in. So, I'll start with a very short scenario. I know most of you have either gone through BLS or ACLS, either has faced it or has just read it or done at least some training or simulation in the courses. But what I'm going to do today is we're just going to stress on a little bit of points that are very common mistakes that we see every day, not from juniors only, but from juniors and seniors in the emergency or outside of the hospital. So our clinical scenario is, let's imagine you're sitting in your emergency department, let's say, on a shift while you're an intern. And let's say it was a quiet shift and you were doing something, you were reading something or discussing a topic with your consultant, and suddenly, from the door, they pushed in a 45-year-old male patient who was unresponsive. And the patient was brought by the family. You have no history, nothing, you don't know what's going on. So, first thing for this patient is, okay, before the ABCs, as long as he's unresponsive, before the vital signs? Okay, so all what you said is right. Thank you. Who said that? Is he alive or not? Number 1. All you said is right. We're going to go over the ABCs, we're going to check the GCS, we're going to check the breathing, we're going to check everything. But he's unresponsive, so is he alive or not? So number 1 is, we've talked about this earlier, is the priority in an unresponsive patient is circulation, and then airway, and then breathing. So number 1 is checking for the pulse. Agree? Okay. So let's say you check the pulse of this patient. You're 45-year-old gentleman, and he had no pulse. Next. Immediately start CPR before everything else. Yes, we're going to check the vital signs. Yes, we're going to check the ABCs. Yes, we're going to check everything. But start CPR is the priority. So, you asked one of your staff to start the CPR, and you gave a specific order for the compressions. How many compressions do we do per minute? 100. I know it's written. At least 100. 100 to 120 compressions per minute, and giving the instruction that you compress hard and fast. And what's your depth? 4 to 5 centimeters approximately, or 1 inch. So not too fast, but not too hard, not too fast and not too hard, but still fast and hard, approximately 100 to 120 compressions per minute. And your ratio of ventilation to compression is 30 to 2 in adults and 15 to 2 in pediatrics. Okay? So next thing, you started the CPR. What do you want to do now? Assess the patient? Ventilation? Okay, IV line? Okay, so let's go through it. So you're going to ask one of your nurses to connect the patient to a monitor, connect him to a defibrillator, and next, you want a set of vital signs. You want to check this patient's temperature, and you want to ask for a glucocheck. Is the temperature and glucocheck important in this patient? Can it be the cause of arrest? Yes, we'll come to that later on. So third thing is, you'll ask someone to get you 2 lines. If not possible, what will you do? Interosseous. Fourth step is stat BBG. And don't forget to ask the relative to stay. Because you have no history, a small amount of history might lead you to what's happening with this patient and might lead you to improving his outcomes later on. So while you ask the relative to stay, if you have an extra staff, send your staff to take history from that relative, and then resume what you were doing. So we still have things that we need to do. We talked about the compressions. We did not talk about the airway. We said that the ratio was 30 to 2, but how? Bagging. So initially, you bag the patient. Okay? So initially, you bag the patient. You insert an oral airway. Everyone knows what an oral airway is? Who doesn't? You all know? So we insert an oral airway, and we start bagging the patient, 30 to 2. And next, we need someone to count our time. Is time important? Yes. And what? To know when to stop. Okay, that's the least priority now. What else? Switch roles, okay. Defibrillation? Medication. And most important is? Checking the pulse. You need someone to count your time, and you ask someone to prepare your equipment for intubation. And once it's ready, you proceed with intubation. When you intubate the patient, what happens to the compression ventilation ratio? Does it change, or is it the same? No relationship? Okay, so how many compressions per minute? It's the same. How many breaths per minute? Okay. So this is one of the important, I'll come to it later, but this is one of the most important steps that a lot of people miss. Even our nurses who are trained on ACLS, even our physicians who are trained on ACLS, when you're in the hectic situation, you just forget. Sometimes the patient has been intubated already, and the person who's doing the compression stops after every 30 compressions. And there's nothing to do. He's already intubated and on a ventilator. So we'll come to the rate in a while. And you ask someone to prepare your medications. Okay, so most important medication and the key medication cardiac arrest is epinephrine. Dose of epinephrine is 1 milligram IV, IO, every 3 to 5 minutes. And this is one of the things sometimes we miss in the situation. If you're not following up with your nurse who is calculating the time, sometimes they forget to give the doses every 3 to 5 minutes. If you don't get feedback from your nurses, you have to keep on asking. Second dose of epinephrine given, yes or no. Third dose given, yes or no. And after the intubation, I just said this a while ago, regardless of the compressions and ventilation, they're not related to each other, so you give one breath every 6 to 7 minutes, total of around 10 to 12 breaths per minute, okay? So key concept number 1 was pulse is the first thing you do before anything else, okay? And when you intubate the patient, compressions are not related to ventilations. Okay, so your 2 minutes are over. What are you gonna do? Stop the compressions and check for the pulse. Reassess who? What? Yes. So you're going to stop the compressions and check for the pulse. And at this time, there's one more thing that you have to do. Anyone? Who said analyze? Analyze what? Analyze the rhythm. So you stop, you check for the pulse, and you look at your monitor and analyze the rhythm. Here, divide the ACLS protocol into 2. You have asystole or PEA, pulseless electrical activity, and on the other hand, you have the pulseless vtach and vfib. Okay, so the first scenario, let's say this patient was in PEA or pulseless electrical activity. So your algorithm goes that you resume the CPR, you stop every 2 minutes and check for the pulse, and check the monitor for any shockable rhythm, and don't forget to give the epinephrine every 3 to 5 minutes. The most important thing in the PEA is look for the reversible causes. H's and T's. So what are the H's and what are the T's? So H's are hypoxia. So patient can, let's say, be a CO poisoning patient, and that's why he arrested. That can be the cause of the arrest. And once you put him on a high dose of oxygen, he might revive. Second thing is hypovolemia. This patient might be in hypovolemic shock, which might have caused his arrest. Acidosis, this patient may be in, let's say, severe DKA, which caused his arrest. You have to correct the causes. Hypo and hyperkalemia and hypothermia. So hyperkalemia is why we sent the VBG early on and resuscitating this patient. Hypothermia is why we asked for temperature, because hypothermia is one of the most commonly missed causes of cardiac arrest. We forget to take the temperature, and we're doing all the resuscitative measures we can, and he's just not reviving. And when we discover it's hypothermia, you just rewarm the patient, and you get the good pulse back again. T's are tension pneumothorax, cardiac tamponade, toxins, PE, and cardiac causes. So we've discussed these earlier on the other sessions, so I'm not going to go in details into them. And then comes the second algorithm, which is pulseless vtach and vfib. So this is what? Vtach, and this is vfib. So what changes here in the algorithm is you definitely resume the CPR, you check the rhythm every 2 minutes, and you check for pulse. Once you identify a shockable rhythm, either the vtach or the vfib, what do you do? Deliver the shock immediately? Okay, while you clear the patient? Okay, so this is one of the most important things that is also missed, and there's always a mistake in this part. So once you see a shockable rhythm on the screen, you need some time to charge your machine, right? A lot of people just stop the CPR while whoever's charging the machine charges. And this is completely wrong, because the minute you stop the CPR, as if you're starting from the 0 point again, as if you haven't done the CPR for, let's say, the last 5 minutes or 10 minutes or 20 minutes. So you never stop the CPR unless the pads are on the patient. When you ask everyone to clear, that minute you stop the CPR and give the shock. Check the pulse every 2 minutes, give the epinephrine every 3 to 5 minutes, and After a couple doses of the shock, if the patient is not responding to the shock, you might go to amiodarone and definitely treat the reversible causes. Another important concept is a lot of people, after they give the shock, they check for the pulse. Is that right? Who says yes? Who says yes? Okay, so what's the right thing to do? Resume CPR and check the pulse after 2 minutes. You do not check the pulse after you give the shock. That is completely wrong, and a lot of people do this. Okay, so now you're giving the shock. You don't know which hospital you're going to be in. Some hospitals are using the monophasic machine, and others are using the biphasic. Do we know the difference? So the difference is in the amount of joules each machine gives. So the monophasic machine gives a less amount of joules than the biphasic, which means that if you have a monophasic machine, you have to give a higher dose of electricity. So if you have a monophasic machine, you give around 360 joules per shock. And if you have a biphasic machine, you give 120 to 200 joules per shock. So, do you know, Mohammed? Exactly. Exactly. So how do you know is that this is one of the important things is that you have to know your environment and the place you're working in. I've known one of the physicians that every hospital she goes to, she spends a couple hours just rounding around the area, asking the nurses and asking the staff, what kind of medications do you have, what kind of machines do you have, what kind of stock do you have, what kind of equipment do you have to prepare for these kind of emergencies. So just keep it in mind, every hospital you go to, ask this question, what kind of defibrillator do you have? Because it makes a lot of difference. And another thing that makes a difference is the electrical pads or the plastic pads that are put on the patient's chest. Which kind of pads are available? Because this one you have to carry yourself. The other pads are already on the patient. You just charge the machine and shock it without touching the patient. You have to know these things. Like, where do you place the pads? So one is going to be on the right upper chest. The other one is going to be on the left lower chest. And the last two concept is after a couple cycles of CPR, let's say you were lucky and your patient revived and he went back to ROSC. What do you need to do now? The most important thing is optimize the post-state of care, which is optimize the cardiopulmonary function, manage the ACS, and prevent end-organ damage. So one of the most important things you do after a patient revives is do a stat ECG. Because this patient might have had an MI, and he was late to come to the hospital, and his MI caused arrest. If this patient revives, and you do an ECG, and you discover he has some ST elevations, let's say in the inferior leads, taking this patient to the cath immediately would save his life. So always keep it in mind, as soon as the patient revives, first thing is you do an ECG. And then you ask for a chest X-ray, and you ask for the other labs and everything else. ECG is a must as soon as he revives. Let's say you were unlucky and unfortunately your patient didn't revive, you've been doing CPR for 30 minutes, 20 minutes. What next? When do you stop? We always have this question in mind, when do you stop CPR? So it's a debatable question and honestly no one knows the answer, but some people say that after 30 minutes, without sustained perfusion, stop the CPR. Some people say, well, if your initial rhythm was asystole, and it's been asystole all the time, you've been doing it for 30 minutes, stop the CPR. Some people say, if there was a prolonged interval between the arrest, the actual arrest, and between the time the patient actually arrived to the hospital, and you've tried for, let's say, 20, 25 minutes, just stop the CPR. And it depends on the comorbidities and the patient's age, definitely. And let's say if the patient has absent brainstem reflexes, which in another word means the patient is brain dead, there's no use of doing a CPR. Definitely you don't check for these things except unless the patient is normothermic, because we said hypothermia is a major cause of arrest, and it is not corrected by defibrillating or any of the resuscitative measures. You have to rewarm the patient. Okay, so what is the most important indicator of ROSC, let's say, or outcome of the patient? It's the end-tidal CO2. So end-tidal CO2 of less than 10 after 20 minutes of resuscitation means the outcomes are bad. Most likely this patient is not gonna revive. So to end my talk, I want to give you some take-home messages. The first thing is, when you have an unresponsive patient, C, and then A, and then B, you check for the pulse first, before the airway and before the circulation. Second is, always stop every 2 minutes and check for the pulse. And after delivering the shock, resume CPR 2 minutes, and then check for the pulse. Never check for the pulse after the defibrillation immediately. And one of the important things is always check for the cause and treat it. H's and T's, always look for them and treat them. And if you can't find an IV access, go for an IO. Don't struggle with the patient. Last thing is request an ECG, chest X-ray after the ROSC. And thank you very much.